So thanks to the organizers for asking me to talk on lumbar facet blocks and root blocks. Now, when myself and Dr. Abrar sat together in planning this program, we wanted that the first hour should be more of theoretical background to the pain procedures in the spine, and the second hour, the second session, will be spent on more on technicalities. So, considering that in mind, I basically rushed through a couple of slides to show you a couple of examples. Basically, one of lumbar facet block and the other of lumbar root block, and then go on to a small clipping of a video. I have a voice in that video, so I just want to retain the voice because it being a provocative procedure, you can listen to the patient's voice. There are a little bit of interruptions in the video, and there is a background noise. It was very hurriedly shot. I beg your pardon for that. So as we know, in the armamentarium of a spine surgeon, facet joint blocks, selective nerve root blocks, epidural steroids, sacroiliac joint injections, and the ganglion power blocks are the typical sort of injections that we do encounter. Rarely do we do pars block and discography, and these are mainly for diagnostic purposes. The others are more for therapeutic, as well as occasionally when we get stuck to isolating the pain generator, we have to rely on these procedures. I'll just share with you a couple of slides on facet joint injections because Dr. Abrar asked me to cover that also. This is, as Abhishek pointed out, it's not a very commonly practiced procedure, but just for the completeness of the talk, it is helpful when the pain generator is the facet joint. And as we all know, facetal pain occurs in extension, discogenic pain occurs more in flexion. Anything between 15%, as Saumyajit quoted, it is about 15 to 30% of patients has facetal involvement, and many of them have a facetal involvement not in isolation. In isolation, they also have additional ligamentous, discogenic back pain incorporated. So it's very difficult to isolate those patients who have only facetal pain. CT and bone scan, especially the SPECT scan, picks it up very well. And these are the standard medications. Typically, bilateral 4-5-5-1 joints are injected. Now, as you know, these are the positions. I will not go into the details of these. And I'll share with you a typical oblique view, which the Scotty dog view, which Anindo so beautifully explained to us a while ago. And that is the area of the facet joint, which you see if you properly angulate your CR so that you can see it right away end on. As you can see, this is the facet. And this is a patient who actually came to us with a unilateral pointing localized back pain. I don't know, I might have got only 2 or 3 such in my 16-year career as a full-time spine surgeon now. And this is an isolated degeneration of the facet joint. Initially, we thought it could be infective. His CRP was normal. There were no other inflammatory markers. History-wise, also, she did not have anything suggestive of an infection. And as you can see on the SPECT scan, there is a bright spot only on that area, and that is the point where we injected. So this is a patient with an isolated facetal pain, matching with the CT scan, as well as the MRI, as well as the bone scan, the SPECT scan, and this is a patient we injected on one facet only. And a typical facet joint would involve bilateral 4-5-5-1, but in this patient, as there was unilateral pain with one facet joint being the pain generator, this was a good diagnostic purposes. We did inject her thrice, and she got quite a good relief of pain. Going on to selective nerve root blocks, it is usually used when pain generator is the nerve root. Root pain occurs in extension or flexion depending on whether it's PID or stenosis, and typically has a radicular distribution. I love the presentation of Saumyajit when he showed us that the root, and he correctly showed us the pictures in which you can understand whether the root is an up-down stenosed root or a front-back stenosed root. And for the young generation of spine surgeons, it's extremely important for them to realize that when it's an up-down stenosis, your surgical aim not only is to decompress the nerve, but also maintain the disc height. Whereas if it is more of a front-back stenosis, if you take out the facet joint and deroof the root completely, even without a cage or even without a disc space distracting device into the disc space, you can get away with it. And as you know, MRI scanning should be done with the parasagittal cuts in the both sides, as well as the axial cuts, and typically unilateral L4 or L5 or S1 roots are injected. And this is the lateral view. It was multiply repeated in the last few lectures. So if this is the lateral view, the needle should come just a millimeter short of the posterior vertebral border. And as you can see, this is the pedicle. The needle has to come to very close proximity to the posterior border because the needle comes out there. And from the anteroposterior view, you can see that it just is about a millimeter below the lower end of the pedicle. Remember that the disc spaces and the end plates should be seen very well. The end plates should be sharply outlined. The C-arm should be placed in such a way, such a lordosis, that the disc spaces are absolutely staring at you. And this is the oblique view in which you can see that if this is the pedicle and this is the neck of the Scotty dog, there is where you inject. This is where you inject. This is L5. So this is an L5 root block in which you can see this is the L5 pedicle, and that is where the needle goes in. That's how it looks on the AP view. It's the L4 and the L5 root block. And if you can look carefully, that's where the needle ends. That's where the needle ends, just a millimeter short of the vertebral body. So I'll show you a small presentation of a video. I just hope it works. The process of L4 causing the L. The joint is shown as two distinct lines. So that is the voice audible?
Voice.
The joint.
I can't tell you. You don't see anything.
Also note that you can see the disc spaces. I'll just unshare and then again share.
Again, the video is not coming here.
Is it working now?
Yeah.
Yes. Yes, you're there. You can see.
This is the point of approach for the L5 root. Is the voice audible? You can go there.
Yeah.
Underneath the eye, that is underneath the pedicle of L5, and just lateral to the neck, which is lateral to the pulse. There's a bit of background noise. I'm sorry for that. Virtually dead AP, if not a little bit of kyphosis so far as the C-arm is concerned. So not to show the position of the C-arm. And the obliquity is much reduced. So when you try to show the S1 pyramid, make sure that the obliquity is place. And the lordosis is absolutely straightened out, if not a slight bit of kyphosis. Now if I put the needle here, that is where the position of the S1 pyramid is. This is actually the posterior sacral pyramid through which you can reach the S1 nerve. So in this particular X-ray, which is about 10 to 15 degrees oblique, not much, this is the end on view of the sacral pedicle. Now, I wish to state here that the S1 pedicle is very highly variant anatomically. Various people have various types and various positions of the S1 pedicle. This is very variable. So you must adjust the C-arm picture accordingly so that you have an end on view of the S1 pedicle. And the posterior foramen of the S1, through which actually no important structure comes out other than some emissary veins, that is the position of the S1 foramen, posterior foramen. And on the superlateral aspect of this, that is the point of target of the S1 root block. Because the S1 root moves like something like this and goes and exits out of the sacral bone to the anterior sacral foramen, which is actually this. But here is where you will be targeting for the posterior sacral foramen. Point to be noted is that the entry point of the sacral foramen is much medial to the entry point of the L5 L5 root block. Appreciate this. কোথায় লাগে? ঠিক আছে, এবারে কমে গেল? কমে গেল? So as you can see, we got a provocative response. And I'm going to take a lateral shot to show you where they are exact position. Now you can see that I'm adjusting the amount which I need to go in. the L5 routing point. Just I am lateral to the posterior foramen. This lateral edge of the posterior foramen as marked on the screen. This is quite a subcutaneous area, so you do not have to take the tip of the needle way far lateral. And then you can just put it in. And as the first bone strikes my needle, I take a shot. So I am a little bit caudal. I need to direct it penny and close. Now I see I can get the loss of resistance and it goes down. Now I take a shot and you see I am dot on the posterior foramen. That it has gone down, as you can check by the amount of needle which is protruding out. দেখুন দাঁড়ান আর লাগবে না এখন দাঁড়ান দেখুন এখন লাগছে না তো পায়ে লাগলে বলবেন So I have just entered into the foramen. As you can see, it's on the superlateral aspect of the posterior foramen. And now as I picture it, she should have a response of the pain. পায়ে লাগছে ঠিক আছে জোরে বলুন ঠিক আছে So that's the foramen. Now I take a lateral shot. You can see the needle has gone into the sacral foramen and it is just touching the posterior aspect of S2. So this is the pedicle of S1, that's the S1, and through this area, approximately through here, the anterior sacral foramen, the S1 root comes out, and you've taken the S1 root there. So this is the L5 root block, this is the S1. As you can see, both of them are from lateral to medial and they just cross the lateral bottom of the pedicle. That's the correct position.
Okay.